Thank you, Dr. Tree. So again, as we started out this morning, we're really going to focus on solutions and all of the things that many of you bring to the table today for our roundtable discussions this afternoon for that, the resources that we need to best serve our patients going forward. So each of us are going to talk about the challenges that we face, but also the things that we see as the future potential solutions for the patients for whom we care. So I just wanted to talk to you a little bit about, the Lieutenant Governor started to get into this for the state, but I wanted to really bring this home for what we're seeing here in Onondaga County, really the scope of the problem. And we serve as the Regional Perinatal Center here at Sydney Upstate and Crouse Hospital, serving 14 counties as well as 18 hospitals. And just looking at the data, and this is a recurring theme that we've heard already throughout the morning. We're going to continue to hear this as a recurring theme. But if you look between 2012, 2013, and then 2015, 2016, these are the numbers of deaths associated with these different types of opioid patients, for patients that are taking fentanyl-related medications or other heroin-related medications. The numbers are really doubling on an annual basis, and this is just Onondaga County, and these are not overdoses or near misses. These are the deaths within the county, so tremendously increased if you're talking about overdoses as well. And Onondaga County has the third highest rate in New York State for newborn-related diagnoses, which is 300 per 10,000, and so it's a tremendous issue within Onondaga County, which, as I recruit residents from around the country, it's very surprising that it's such an issue here in Onondaga County as we're caring for patients. I think physicians, when they come to this area, are very surprised by the issues and the patients that we're caring for and the tremendous need. And this graph that came from the county health department, I think really brings this home very well, that the blue line is New York State excluding New York City, while the red line is Onondaga County. See that we're really doubling the rate, and the slope of that graph is also quite concerning as well. So what we do at Crouse Hospital, and I think this is probably consistent with what many of you are doing throughout the state, is having a multidisciplinary team in the Regional Perinatal Center. Many of these patients are seeing a perinatologist for consultation and then have the certified nurse midwives caring for them. We have a very good practice in the centering group, and our nurse midwives are here today that represent that group that provide care. In the centering group, they're very successful. Getting them to see the neonatologist is a big part of that, making sure that the neonatologist can counsel them with respect to the issues with legality, as well as how those patients are cared for when the babies are born. Many of these patients are then sent to the OB/GYN Generalist group for care throughout their pregnancy. Addiction medicine, getting them in early for medication-assisted therapy, as we've heard is a recurrent theme, early and throughout the entire pregnancy is a very important part of this as well, and having social work see them as well. All patients are screened, and this is all patients, making it very clear that it needs to be all patients, are screened by one or two tools, and you have in your handout as well the FACOG practice bulletin that suggests two tools that you can use. So the 4 Ps or CRAFT, and it goes through the different elements of these two tools that you can use. There are several different tools. The key element, again, that we've heard already this morning is that using some type of verbal tool is very important. And then again, continuing the medication-assisted therapy throughout pregnancy and not to taper this therapy. The reason for this, of course, is that the patients are at risk for, and we're seeing all of these manifestations in pregnancy. We're seeing either poor or late or no prenatal care, which results in abruption. We see placental insufficiency, growth restriction. Many of our patients are coming in really on polypharmacy, so it's not just opioids, but many of them are coming in acutely either withdrawing or acutely intoxicated on heroin as well, or methadone that they're getting off the street, or other opioids that they're getting, as was described earlier, not necessarily prescribed or could have been prescribed, as well as cocaine. And so we're seeing abruptio, we're seeing preterm labor, preeclampsia. And we are treating all of these obstetric diagnoses, but also as the primary care providers for these patients during pregnancy, we're also treating the psychiatric issues as their providers during the pregnancy in the outpatient setting as well as in the inpatient setting. But we're also treating the acute withdrawal, and that'll get into one of the concerns and the solutions that I have that we really need to get into. So we're treating them as they're in labor and delivery or antepartum if they come in the antepartum state when they're acutely withdrawing from cocaine as well as opiates. And we're treating them with Atarax, clonidine, benzodiazepines, potentially starting them for the first time on methadone. And our supportive teams, including the residents, the physician providers, nurse practitioners, and nurses on our teams are doing the COW scores, the clinical opiate withdrawal scales as well. So just for those of you, I'm sure most of you are aware and have an understanding of the COW scores, but this is the chart showing what those look like. So looking for all the signs of withdrawal, scoring those, and seeing on an ongoing basis the need for the patients acutely with respect to benzodiazepines and tapering those, as well as the Atarax for the histamine type withdrawal symptoms that they have, and also the clonidine that we're treating them with. The two things that I really wanted to focus on that really go back to many of these issues that we're seeing, both in the outpatient setting and the inpatient setting, are an increase in psychiatric support. The state of Massachusetts has a program called We Path for Moms, where they have 2 FTEs, psychiatrists, that are available via telemedicine as a support for physicians, providers throughout the state of Massachusetts to allow a provider seeing a patient in an outpatient setting to consult with them via telemedicine. So if you need to start a patient on an antidepressant, but you're not sure whether or not this patient needs a referral to the ER acutely, potentially she needs to be acutely inpatient, you can have a telemedicine visit with that psychiatrist because the state has established that system. So this is something that we're working on an advocacy level as FACOG New York and some of our collaborating teams to try to push this forward with legislation and also with the governor's office in New York, because we feel that this would be very successful, because increased psychiatric support is something that we definitely need throughout the state, because as providers, again, and I think all of you, I'm not saying anything that's new to you, but I think that a huge part of this issue is that we need enhanced psychiatric support, because all of us are providing that support at this time. An additional piece of this is that we really need further education for providers on management of acute withdrawal, the COW scores, and also to enable residencies and to enable OBGYN departments across the board, family medicine departments as well, to further teach their providers on best practices for management of acute withdrawal. This is something that many of us are learning, if not all of us are learning on the fly out of necessity. If we look at, especially in New York State, where we have the hemorrhage protocols, where a patient comes in with has acute delivery and has a postpartum hemorrhage, we know immediately to, if she's not hypertensive, give her methergin, and then if that's not working, move to carboprost, and then move to misoprostol. And we've got a beautiful poster on the wall to go through the assessment tool and adequately address that issue and save her life. And this is as much a life-threatening issue that we're seeing on a daily basis, that is a constant threat to our patients, to the moms, and to the babies. And we could as easily have that beautiful poster on the wall of all the labor and delivery units going through the withdrawal protocols and the COW scores, so that our nursing teams and our physician teams and our resident teams are not scrambling and making up these protocols on small pocket resources that they've created on their own. So that's the vision, part of the vision that I have at least, or resource that I would see that we would need to address one of these many issues as we combat this tremendous issue that we have.